only less than 5 minutes. If they go more than 5 minutes, they have no chance to get the winner of the sessions. So I will invite the first presentation. I don't know if we have for all presenter should be in front of in the first row of the seat. So I invited Ibu Emi on the riverbank side learning activities, Mariam from Georgia, Nino also from Georgia. Actually, both of Nino and Mariam are sisters. Jiang Ming Wang from China, Herawati, Bu Herawati, ya. Nanti diperkenalkan ya. Saya belum kenal. Then we invite Lamia from Egypt, Eri Wahyu Ningsih from Purwokerto, Sani Wada from India, and Fiona Amelia from Jakarta. Not from Indonesia, she's from Jakarta. Okay, where is Bu Emi? Okay, so the PowerPoint thing is there, right? So please present the first. Okay, Bu Emi, you can start now. I think it is good idea to present while you are standing in the front. So, or you can standing in the front here. That's okay too. So after the presentation, I ask your comments. I don't want you to ask, but comments, more comments rather than ask questions. But of course, will be interactive after that.
Thank you for the time. Let me take a deep breath for a while. So, good morning, audience, for ladies and gentlemen. Thankfully for Lord for giving me the chance to be here, to stand here, to be present, stand here to presenting my poster presentation in research, policy and action to burden the non-communicable disease symposium. My name is Emi Nirmalasari. I'm the one of representative from our team poster. My poster made by collaboration among the health policy and management, health behavior and promotion, and health system information. They are my team was over there. They are Madelina Aryani from health policy management, and me also from health policy management, and Dr. Vera Ginting from health behavior and promotion, and the last is Ms. Sri Herlina from health system information. So we are a postgraduate student in public health, University of Gajah Mada. Before we start my presentation poster, I would like to invite all of you all to see my photos here. Can you see this picture? This is a river in Banjarmasin, one of river Banjarmasin in south of Kalimantan. The name of the river is Pekapuran River. It was located in the district of the Pekapuran Raya in south of Kalimantan, Banjarmasin. First, I want to show. I want to tell about the short story about the social habit, the children who lives in the riverbank areas. Uh, Social habit, the children always use the river to swim when the river receded or the river becomes dirty. So we think this is the bad habit for their health, and also for the dangerous for them, because it will be dangerous, and it will be it they will get the accident for the they will get the accident when they're swimming in the shallow water, and it related to the non-communicable disease. So, for your information, disease transmission is also higher in these areas, and infectious diseases are still high also. So the MCLR that called Movement of Children Love Rivers is the one activity from the university to help to redirect the children from swimming in the dirty or ebbing river water to other physical activity, such as gymnastics. You can see the gymnastics here. The gymnastics were conducted in the beginning and in the end of the meetings. And health education. We use the method for playing games here to redirect their desire want to swim when the river receded or dirty.
1 minute left. You should be very quickly complete your presentation.
Yes. Thank you, Mr. Mubashir. This activity successfully redirecting the children's desire to not swim when the water receded. And the MCLR involved the 33 children at age 5 until 12 years old, and then head of primary health centers and cadres, and also hamlet leaders. To provide her house to this activity. And
okay, the time is over. The time is over for you.
Thank you.
Okay, give an applause.
Thank you for my presentation.
Later we will discuss if we have time. Okay? Mariam Maglakelich.
Good morning. It's my pleasure to present the results of breast and cervical cancer prevention program in Georgia, which has been running since 2008, and it's a big success. And this is the program that Georgian government is really proud of. So I will, in brief, tell you the story, how it started, and what is the root of its success. So in 2008, the program started in 2008 with the initiative of National Reproductive Health Council, which is also chaired by First Lady of Georgia, and was supported by Tbilisi. Okay, you can't hear me? Oh, yeah. Sure. was supported by Ministry of Labor, Health and Social Affairs of Georgia, as well as Municipality of Tbilisi and United Nations Fund, Population Fund Georgia office. So you had like already 4 stakeholders who invested their budget in order for the program to run. The goal of the program was to reduce the morbidity and mortality caused by breast and cervical cancers. Just to give you some figures, the breast cancer incidence in Georgia is about 38 per 100,000, and cervical cancer is about 9 per 100,000. So that makes us, Georgia, for breast cancer, the prevalence is still lower than in Western European countries, but higher than in Asian countries. And for cervical cancer, like the trend is, as you know, that in Central and Eastern Europe it's very common. So it's still lower than those rates, but but higher than in Western Europe, because in Western Europe cervical cancer is not that much of a problem. So the program is built that the target group for cervical cancer is 25 to 60-year-old once per every 3 years screening intervals, and for breast cancer it's 40 to 70-year age, once per 2 years screening intervals. The program results already demonstrated that one of the main goals, which is detection of the cancers at the early stage, because as we know, if you detect cancer on the early stage, it's easier to handle it, and that is one of the goals. And for cervical cancer, it's absolutely totally even preventable, because it's caused by a virus. So the program already showed that, if you look at the transition, from 2008 and 2010, the ratio of detection of cancer on early stages really increased, and on the late stages it really decreased. So it was also one of the success. But there are still lots of challenges to be carried out. Just to highlight how the structure of the program, from the upstream level, as I told you, there is still the government will, and which is manifested in budget allocation from the federal government, as well as you have another player, which is donor, UNFPA. On the midstream level, really covers sensitization of population, meaning awareness raising campaigns and spreading the information, and just to letting people know that this service is necessary and available for free, which is also important. And also quality control measures, because constantly the medical staff are undergoing trainings from Western European institutions, and quality control, that is a challenge everywhere, but we do our best to tackle this. And on the downstream level, we can consider the service delivery, of course, this is mammograms, biopsies if needed, pap smears, and so on. And these are being carried out in different contractor institutions of the National Screening Center. So challenges. For the moment, the main challenge still remains low coverage of target population, which is about 15% for both programs. Because program is there, it's available for free, but still, especially in rural areas, the coverage is really low. So that shows up that awareness and information spreading, sensitization is something to be focused on, and more efforts need to be carried out in this direction. And also, as you know, in order for a screening program to give the best results, it is important to have an organized manner of screening, meaning that the screening program managers and administration need to constantly call, and this is called call recall system, as you know, so they need to really remind women that it is time for you to come back. And future plans: increase geographical accessibility, create cancer register, because we don't have it, and also to implement already pilot organized screening program in Tbilisi.
Okay, the time is over.
Okay, sorry.
Let's have a clap for Maria. Let's go to Nino.
Good morning, everyone. I would like to present a Good morning once again. My poster is related to the reduction of the prevalence of non-communicable diseases by looking at it from social determinants of health perspective and by really tackling the tobacco control issue in my country, which is one of the main problems. Likewise, like in many developing countries and especially Indonesia, because we've learned what is the context here related to tobacco control. So I would like to share the experience of Georgia. Just basic statistics, tobacco consumption is quite high in Georgia, one of the highest in whole European region. It's about 30% and 55% in men, whereas in women it's just 5%, but the trend is increasing. Georgia has signed the WHO Framework Convention for Tobacco Control actually in 2003 and in 2006 and ratified in 2006. But since then, not many things have been changed because of once again, the governmental will was not there, which is one of the most important things to really address this issue from the social determinants of health perspective. But recently, with the initiative of the Prime Minister of Georgia, we have established a multi-sectoral state committee, which consists of, chaired by himself, by Prime Minister, and consists of several ministers, the members of the committee are the several ministers, 10 ministers from different ministries, which is like one of the best examples how health-related issues can be really addressed by multi-sectoral collaboration between different sectors. And the main goal of this committee was to really look at this issue from the social determinants perspective and to plan some upstream, midstream, and downstream measures for tackling tobacco issue in Georgia and to really address all the articles and provisions which are in the WHO FCTC. So the main things which are like main provisions and main goals of the committee are from the upstream perspective to establish the committee and collaboration with, as I've mentioned, is now already established, and within this committee to elaborate the action plan, strategy, and some legislations to the relevant laws. Which is very important and necessary. And good news is that our action plan is already approved by the government of Georgia, whereas we're now in the process of approving the strategy and the amendments in the laws. So this is the main base to do the further changes, which are then related to the taxation, which is one of the most effective measure to tackle also tobacco, and all different ministries are involved, because as you know, related to taxation, it's the responsibility of Ministry of Finance. Also introducing the licensing system, which is the responsibility of the Ministry of Economy. Also smoking ban in public places, and some midstream measures like educating the public, awareness raising campaigns, and to also strengthen the tobacco cessation services in Georgia and really strengthen the capacity of the quit line. So this is basically it. Thank you.
Nino has 1 minute left, but that is very good. That's very good. That's good point, actually. Okay, please, Xing Bang Wang. Pak Wang is from China. The last time you made the better of the mark.
Okay. Good morning. 早上好. It's in Chinese. So I come from China. Currently, I'm working in Nanjing Medical University. The topic is about hypertension. When I arrived in Georgia, I noticed about that people in Indonesia eat a lot of sugar, right? But in China, people eat a lot of salt. Which type of disease is significantly associated with higher consumption of salt? Hypertension. So currently, I think hypertension is not a problem in Indonesia, but in China, it's a big public health issue. The prevalence of hypertension in China now have increased to more than nearly 20%. Can you imagine the huge number of patients? We have a lot of drugs for the treatment of hypertension, but the problem is that you need to swallow the tablets for the whole lifetime. So sometimes people forget to take the drugs. So there is another kind of disease like tuberculosis. How to improve the patient's adherence to anti-tuberculosis treatment? Which type of strategy we have used? Do you know? For treating tuberculosis. You don't know? So, direct observed therapy. That's each time you need somebody observing, you take the drugs. So, based on this experience, we hypothesized that maybe we can ask somebody else, like your family members, your friends, to supervise you taking antihypertensive drugs. So that's the hypothesis of this study. This study was designed as two parts. First, we performed a pilot study. That's a self-controlled intervention study without external controls. If you have studied epidemiology, you must be familiar with this epidemiological study designs. But the disadvantage of this self-controlled design is that the evidence is not so strong. After 6 months intervention, we observed a significantly improved adherence and the success of blood pressure controlling rate. Then we performed another randomized controlled study. It's difficult to do individualized randomization because the patients will communicate each other. So we select 4 communities. Then that's a cluster randomization. Currently, we have followed up for 6 months. I analyzed some data and found some increase of the treatment adherence, but the controlling rate of blood pressure the difference is not so significant. We expect to follow for at least 1 year, maybe several months later we will do another analysis to see whether this strategy is good or not. So thank you.
Thank you, Wang. You just spent 4 minutes, less than 4 minutes. That's good. Okay, we invite Bu Herawati. It's Miss Herawati, it's not Bu Herawati. You could introduce yourself.
Good morning, everybody. Allow me to introduce myself. My name is Hairawati Idris. I'm from Sriwijaya University, Faculty of Public Health. Today I will share my study. The topic is socioeconomic factors that influence incidence of hypertension, evidence from Indonesia. As we know that hypertension is one problem big problem in public health. And now the increase of hypertension not only in developed countries but also in developed countries. And Indonesia is the third leading cause of the death of Indonesia after stroke and tuberculosis. And then it also cause of the complication disease of renal failure and the heart failure, peripheral failure, and then it will be make high morbidity and mortality. The purpose of study is to want to analyze socioeconomic factors that happen in Indonesia, specific for hypertension. The sample is from secondary data, Indonesia Family Life Survey in 2007. There are 11,511 individuals for more than 40 years old. Is the family life service just cover 13 covers in province in Indonesia. The method for the study is logit model. It's one of non-linear regression that produce equation. Dependent variable is categoric. The basic category is 0 and 1. 0, in this case, I divide 1 for respondent has this diagnosis hypertension and the 0 has no hypertension. And we can see that the result, the variable dependent is hypertension. The independent consists of age, marital status, economic status, year schooling, and then region in Sumatra, Jawa, Bali, and East area, and then employment and area status. Almost of these variable use dummy variable, and also independent variable hypertension 1 and 0. And from the result we can see that there are most variable significant in 1, 10, and 5% respectively. And then from the age is the significant the people who has more than 40 years old has probability it's not clear, has more probability to get hypertension. And also in marital status, person who has married high probability to get hypertension than unmarried. And also employment status, and then region in Sumatra has probability high hypertension and the other area. And then area status in urban has probability has hypertension and the other. And the last is conclusion from the analysis that the risk factor of socioeconomic influence in hypertension is economic status, gender, sex, employment, marital status, region in Sumatra, and area status. I think that's all. Thank you.
Yeah, so far Herawati is the quickest so far. Now we invite Lamia. It is not necessary to be quick, but it's very 5 minutes is okay. Lamia is for a magic.
Lamia.
Yeah, that's right. Yeah, that's right. Yeah, you need to be.
How cool is this? So cool that I got my poster in this conference. Thank you very much for the time. I'm going to keep my water here. Saya nam Lamia, saya dari Mesir, and I'm an aku cinta padamu for everybody, which means I love you, Professor. My poster was actually about childhood obesity and diabetes among Egyptian adolescents. The subject is actually quite important. I don't remember figures, but that's why I'm reading from the paper, that the WHO estimates that there are about 43 million obese children under 5 worldwide. That's a lot of children. And 75% are found in middle and low income countries. In North Africa, 1 in 6 of preschool children is overweight. That's a lot as well. Now, for Egypt, 20% of our preschoolers were overweight in a study that was done in 2008. Obviously, obesity is a golden door for somebody. Diabetes. Come on, you guys. The poster was based on a study that was a survey that was done by the national. It was a national survey in Egypt. It was done on diet, nutrition, and the prevention of chronic non-communicable diseases. And it was done by our National Nutrition Institute in 2010. It was done by structured questionnaires where we gave the questionnaires to the mothers, and they were about their medical history, their dietary history, and their social history for the children, obviously. And it was done on about 4,200 children. It's a very big study, especially in a country as Egypt. You really can't get that many people to do a study for you. And it was done to explore any link between diabetes and obesity, which obviously exists, and to identify social determinants of obesity. And they found that there are many social determinants in Egypt that exist that make the children obese. And it would be that there's something called nutrition transition. It means that when the children stop eating healthy food and they shift into other foods, you know, that big company with the chicken company with the little toy in the that makes it very attractive for children. Drinking sodas, a diet that doesn't have fiber, doesn't have polyunsaturated fatty acids, low physical exercise. All these were found as social determinants of obesity. Then we found aggressive advertising campaigns. Aggressive advertising campaigns that advertised the food so much, always on the cartoon channels, that it was always the toy that was in whatever. Anyway, so those were the social determinants that we found in the children that had it. Never mind. Just a second. And we also found something very interesting, which was that there was social, cultural, and traditional beliefs that mothers and grandmothers had beliefs in their minds, ingrained in their brains, that this is good for my child. I have to feed my child butter. I have to feed my child ghee, which is another form of butter. And they found in a study in Greece that mothers or grandmothers who cooked in the house, when there's a grandmother who cooks, children in that household will be more obese. Then the study just shows us this little pie chart here that shows how many children were obese. We found in these 4,000 children, about 0.7% of them were obese. It doesn't sound like a lot, but when you think that these are preschool children, it's actually a lot. And then there's a staggering number, which is 16.4 children were pre-diabetic. That means that they have a very, very high predisposition to become obese. Now, the study is actually performed by a doctor that I know is called Dr. Nihal Abul Aila. I must mention her because I didn't have space for references, sorry. My conclusions were obviously that obesity is a growing problem in Egypt. It makes it a very good candidate for screening. Somebody else was talking about screening. Very important for screening. Yes, it was Makkah. And a population-based prevalence study would be important because we have to find out why these children are getting obese, how we can detect children who already have pre-diabetes or have diabetes, and there will be a school-based program with lunch programs. This has been implemented in some of the European countries. There's a very famous chef called Jamie Oliver, who handled it. He's English. But he didn't handle it in Egypt, but we were thinking about doing it with having a meal that consisted of dates, because, you know, dates is the thing that we grow and it's very nutritious. And there would be an upstream governmental policy. We've talked about upstream a lot, all of us, because we took it in our course and Professor Mubashir gave it to us. Upstream means that it's from the government, that it's up there. It's not downstream. Downstream is when a doctor gives a person a pill and they get better. That's downstream. But upstream, just for those of us who weren't following that bit, because we had it in all our presentations, upstream is when the government does something to make lifestyle changes that, you know, like China does with the bicycles. You know, you have to ride a bicycle, that kind of thing. Well, obviously. Okay. So that was the presentation. I really hope you have a look at the poster. It's not as attractive as the others, but a lot of work has gone into this. It's not a very big study, but it was nationwide. Thank you. Terima kasih. How much?
5 minutes. Stop. Okay, we back to participant from Indonesia, Bu Eri. Actually, this morning should be Bu Fatwa, but Bu Eri we make in the first session, but Bu Fatwa will be in the second session. Bu Eri coming from Purwokerto.
Thank you, Pak Mubashir. Assalamualaikum warahmatullahi wabarakatuh. Okay, I'll introduce myself first. My name is Eri Wahyuningsih from Jenderal Sudirman University, Faculty of Medicine and Health Sciences. I'd like to present my posters entitled Mental Health of Women Domestic Workers in Foreign Countries and Families Left. I'm quite nervous. For Indonesian people, we know that Indonesia contributes high number of migrant workers. In year 1994 to 2007, it shows roughly 5 million people left the country to find a job. And the women count 3 times of men. Mostly they leave country due to their poverty, and overseas they work in domestic sectors or informal sectors. Due to this problem, the women migrant workers will face many problems. Considering time period, their problems will be met before they leave the country, during their working period overseas, and after they get back home to the origin countries. And those problems are not for or came for herself, but also affected other parts. They are the husbands or the spouses, and also the children they left home. In general, the problems commonly found of the woman migrant worker are they have to work in different cultures. They also have to face the important employers, uncertain payment, no leaves, restriction of making communication with the families left, and also they are at the high risk to be abused sexually and physically. And this problem commonly neglected because they work in domestic area, which is hard to be supervised or observed that they work in inappropriate working hours. For example, if we work 8 hours per day, we cannot share that they work that long. Or if we work 5 days a week, we cannot share also that they work 5 days a week. And the payment is also uncertain. While at home, in the origin country, the husband's sexual behavior is a risk factor for HIV/AIDS or other STIs. The children also will have no sufficient support to grow and develop optimally. And this one is also commonly neglected, that family at home who receive the remittance use it for short-term use only, with no long-term investment or saving. So, from those problems, then I suggested some policies related to the social determinant of health, and I divided into 3 phases. First is the downstream policies, which will be applied to the main target group. Those are improving working skills for women to expand their job opportunity, improving financial management skill for low-income family, ensure family planning access for low-income family to allow them build wealthier family. In the midstream policies, we need to apply that the women supposed to be empowered so they can involve in eradication of poverty. We also have to ensure that all migrant workers leave country safely and work in good environment. And we also need to build a community parenting for migrant workers' children. In upstream policies, we need a regulation of health tests and screening among migrant workers and her family members. We also need a regulation of services for children left behind. And also, I like this is one of my favorite parts. We need a regulation of pension fund to save their remittance. So after they get back home, they have saving and they can start a new, better life. That is my poster. Hopefully it will be inform you appropriately and consider mental health of migrant workers as a part of non-communicable disease that need to be managed. And using the framework of social determinant health would give me advantages to deal with this problem. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Yeah, still have 10 minutes. Yes. Okay, we invite a participant from India, Pak Sani Wadwa. I think this will be the best outlook, right? Okay.
Yeah, everybody can hear me, right? Yeah. Okay, Assalamualaikum warahmatullahi wabarakatuh. I'm Sunny and I'm from India. I'm a medical doctor and now I'm studying Masters in Public Health from Gajah Mada University. And saya bisa bahasa Indonesia juga. Judul saya tentang tobacco dengan betel. You might not be knowing what is betel. I will just like to highlight some of the points about betel. Betel is known as pinang. Everybody knows, right? Pinang? Yes. And it is also known as down serine. Yeah. In India, people are very much addicted to down serine. And I was afraid that when I came to Indonesia, people are talking about smoking always. But they're not talking about these betel nuts. Although it is a serious problem in India, and it is one of the major causes of the oral cancer in India. So I would just like to tell you about some of the figures in India, that in India, total production in 2010 di tahun 2010, produksi di India itu terbesar 600.000 metrik ton. Dan kalau dibanding dengan Indonesia itu cuma 60.000 metrik ton. Jadi jauh lebih besar di India produksinya. Kalau produksi berarti konsumsi juga besar. Jadi India is the largest producer as well as the consumer of these betel nuts. So I would just like to reflect some of the scientific points of the betel nuts. That betel nut has been considered as a carcinogen by International Agency for Cancer on Research on Cancer, IARC. So they consider that it is a carcinogen which contains Schedule 4 poison. So it is very much poisonous. So I made some of the studies related to that, and it was about in north of India, that because they are producing and they are consuming a lot of betel nuts, and the cross-sectional study was done, and 1,200 patients were included, one of the dental hospital di Rumah Sakit Gigi. 1,200 orang masuk dan mereka bikin penelitian tentang itu. And the cross-sectional studies say that males were commonly affected as well as the females, and they had high risk of oral cancer. So di India 9,5% itu dari 100.000 orang itu penderita kanker di India, dan 10% dari itu penderita kanker oral. That means 10% of total cancers in India is oral cancers. So my study is based on that. So they did the study, and betel nut is this one, because they eat and they make the teeth, discoloration of the teeth. You can see this. And this is the example of the oral cancer. So what I want to say is that in India we have made so many measures. Government has tried to do so many upliftment in these procedures, but that is all on paper. Cuman di kertas saja, enggak ada yang melakukan seperti Indonesia. Dan saya mau request the government of India that they should make some of the procedures to ban this product, because this product is very carcinogenic. Kalau kita lihat sejahtera di India, India kan banyak orang kalau mati, meninggal, itu dibakar, bukan dikubur. Jadi kalau orang meninggal di India, dibakar terus dikasih betel, karena itu culture orang India. Jadi saya mau, kalau mereka mau kultivasi, if they want to cultivate this product, there is no problem in that, but they should not use it for the consumption. Tapi mereka tidak boleh. Jadi government atau pemerintah di India itu harus ban this product, but not for the consumption, but for the cultivation it is okay. So this is my first upstream advice to India. And they should also make some of the subsidies to the farmers, yang petani, untuk mereka kalau bisa berhenti ya berhenti dan ganti dengan crop line. They should cultivate in that farm some other products, not the betel products. And also they must put some of the health taxes on tobacco, so that people are afraid to buy these products. So this is one of my research from India. That's all. Thank you.
For our last poster, Fiona Amelia. Fiona from Indonesia, right?
Yeah. Still morning, maybe. Good morning, ladies and gentlemen. Thank you for this opportunity. My name is Fiona, and I am from International Health Program, Graduate School of Public Health, Universitas Gadjah Mada. And I proposed this study about obesity in Indonesia. We know that obesity is the root causes of many NCDs in Indonesia, like diabetes, cardiovascular disease, and also certain cancers. So if we tackle obesity, fortunately, we can also reduce the number of NCD cases in Indonesia. Maybe this obesity-related cases is not really gain attention from the people, because many are still paying attention for the NCDs itself, like ischemic heart disease, stroke, and so on. But actually, we have to see that the obesity trend in Indonesia is really alarming. I want to explain a bit that the burden of NCDs that 2.3% of global dailies are caused by overweight and obesity. And in Southeast Asia regions, among the 11 countries, Indonesia is ranked 6th with 21% proportion for obesity among adults. And also, since 1995 until 2010, there is an increasing trend of obesity even in children, and in children under 5 years especially, and adults, of course. To sum up, we can see from the table that from 1995 until 2010, for both sexes, the proportion of obese people is doubled. In 1995, the proportion of obese adults is about 12%, and in 2010, it's almost 22%. So the proportion is almost double. And for children under 5 years, maybe I did not put the graph over here. In the Basic Health Survey in 2007, the proportion of obese children under 5 years is 12.2%, while its counterpart, the malnutritious children, is 14.4%. So the difference is only about 2.2%. And we know that it causes the double burden of malnutrition problem in Indonesia. And I made some policy recommendations from the upstream approach and to downstream approach to tackle this obesity problem. For the upstream approach, maybe I just want to highlight some things that might be eligible for the government to do. First of all, they have to provide public places for exercises with low cost or even free public places for exercise and proper public transportation. It's a big homework, I think, and it might be 10 years or 15 years from now, it would happen really, but we should start from now. And also we could limit the sales and the use of private vehicles and increase taxes and restrict advertising of selected high-calorie foods and sugar-sweetened beverage, especially soda and beverage like, cocoa drink and so on that sell to the children. And a policy to limit sales of unhealthy food inside educational institutions' cafeteria, such as in a university or in a school's cafeteria. They should not provide like sodas, cocoa drink, and so on, and they should provide healthy foods for the children. For the midstream approach, we should promote public awareness campaign about obesity, that obesity is alarming, and we need to do something from now. And also to promote exclusive breastfeeding. I know it's already been done in many places, but maybe the implementation is still lacking. And also to train for healthcare personnel to give health promotion about obesity and also exclusive breastfeeding. And for the downstream approach, it's a standard method like as a medical doctor or healthcare provider, we could provide screening for high-risk individuals, like Lamia also said, and also provide special clinic for comprehensive obesity management, not only from the biophysical dimension, but also from the social and mental dimension, since we know that many obese teenagers or adolescents especially have depression. Like Ms. Maria Nelson said, that in Sweden many adolescents are depressed because of their obese figure. So I think the most appropriate approach now is for the midstream and downstream approach, as we know that maybe for now we cannot rely on the government to do something, but we can always advocate them and approach them in creative ways to help us tackle this obesity in Indonesia. And that's my presentation. Thank you for listening.
Well, that's 5 minutes up. That's good. Okay, we have time about 15 minutes to make comments. Don't ask questions because that long answers. We like comment. The shorter, the better. Okay, from that side. Oh, this is really short then. Any ideas that you got from the posters? Any comments? Oh, this is very good then. From participant to other participant, you can ask questions. Yeah. Actually, comments, but not question. But
no questions.
Okay.
No, I was actually thinking, would it be that if has India started with tobacco control? I mean, because they've already, this betel nut obviously is causing a lot of oral cancer because it is actually chewed, but lots of people in Europe and in America actually chew tobacco as well. So has the program for non-smoking in tobacco been underway before we start this betel program?
Okay. Yeah, that's okay.
Okay, I accept this question, no problem.
Yeah. Yes.
Yeah, actually, there are certain areas in which this program has been. There are certain areas in India. Because in India we have different kind of states which are conflicted states, like Andhra Pradesh, Manipur, and Kashmir. Yeah, because they don't fall under the constitution of India as a whole. So they have the constitution themselves. So, and this northeastern side, and that is the most commonly affected with this oral cancer because of betel nuts. So we have already amended, FCTC has already been signed in 2010, and they are implementing it. But it is not followed yet. Anti-tobacco. Yeah, but there is no anti-betel. Yeah. But they say that when betel is mixed with tobacco, it has more higher incidence of causing this oral cancer. Yeah, that is known as betel quid. Betel quid is mixture of betel leaves with tobacco and betel nut.
Okay,
which is known as down serine in here. Yeah.
Thank you, Sani. Now I open comments on Bahasa Indonesia. Probably you have more ideas in Bahasa Indonesia rather than Bahasa Inggris. If not, then I give you example from Bahasa Jawa then. Okay, come. We have 10 minutes more. Pak Slamet. Pak Slamet should be a very good commentator usually. So you have some ideas to comment?
Yeah, just I appreciate all of the presentation because it's very interesting. Non-communicable disease is very interesting actually, and now more and more more important for us. And it's interesting about the migrant workers, for instance, but I'm not sure how about the research will be done for the very wide perspective, you know. Okay.
Thank you, Pak Slamet. Probably from jury. Bu Maria, have some words. Thank you. The jury of the posters and presentations.
I just want to give a comment to you that you've done a good job, really good job. Interesting to listen to you. And it was also very nice to see that there were some very clear presentations with a nice design. And also, I would also like to say that many of the posters also, well, most of the posters has really gone for huge public health problems that are important to address. So that was also very nice to see. So that's my comment. Thank you.
We also hear, thank you, Maria. We have also a special guest here, Pak Yodi, probably something. At the end, okay. Buyayi. Okay. Pak Lutfan, the jury. Okay. If that is the case, I want to close this session. So we have about 10 minutes left. But that is good because we have a bit less more than we have to speak up. Let's close this session. Thank you for the participants. Give them a big applause. And for So the winner, I think, should be at the end of the session, second session, and not to be announced this time. So at the second sessions.
Thank you for Prof. Mubasir and all of the poster presenter in the first session. Well done. And ladies and gentlemen, before we proceed to our next agenda, I would like to inform you that all materials can be downloaded. At symposium.fk, bahasa Indonesia aja ya, symposium with y.fk.ugm.ac.id supaya nggak salah /NCD atau NCD, okay? And you can see the live streaming in fk.ugm.ac.id, okay? That's bahasa. Okay. For the next 1 hour, we will have lunch, and you are all welcome to enjoy the meals and drink outside this room, of course. And we will continue with the next session, poster presentation, session 2, with 9 poster presenter, and 1 hour from now, I think. Or maybe 1 hour and 5 minutes. For the additional information, the CDs and certificates will be on the registration desk after we closing this symposium. Thank you very much, and see you at 13 o'clock.